Okay.
There we go. And we are live. That's great. Hello and welcome, everybody. I am Tamsin Murphy, registered dietitian and head of content here at Nutrition Network. And today's conversation is a really exciting one, especially for those of us who are passionate about metabolic health, cardiovascular risk, and therapeutic nutrition. We are joined by none other than Dr. Matthew Budoff, an internationally respected preventative cardiologist and professor of medicine at UCLA. Dr. Budoff is widely recognized for his work in coronary imaging and cardiovascular prevention, and I think many of you might know him particularly well from a pivotal study that he published just last year. Um, it was entitled, it's actually called the Keto Trial. It's entitled Carbohydrate Restriction Induced Elevations in LDL Cholesterol and Atherosclerosis. So I know many of you might know Dave Feltman in this space and his lean mass hyperresponder phenotype hypothesis. And this study, I think, was it's one of the studies to test that hypothesis amongst other things. But I'm sure Dr. Budoff wouldn't mind elucidating us a little bit more about that. But we're also here not primarily actually to discuss the study, although I think we can't help but ask a few questions about it. But primarily he's here to discuss cardiovascular risk assessments, which I suppose were involved in the study. And his lecture on that topic, on cardiovascular risk assessments, is also featured in our newly launched Mastering Metabolic Metrics clinical training, which was created by Nutrition Network in collaboration with Keto Mojo. And we're also thrilled to announce that our cardiovascular health training will be launching at the end of this month, which will expand even further on this cutting edge clinical content. So sign up for that new cardiovascular health training before the 28th of August when it launches, and you'll get a 30% early bird discount. Just email support@nutrition-network.org. So, Dr. Budoff, I think what many clinicians, including myself, are so excited about this lecture that you've done on cardiovascular risk assessments is around the confusion about what we should be testing and what is truly indicative of cardiovascular risk. Do we look at blood markers like your lipogram? Do we look at high sensitivity CRP? Do we, do we trust these coronary artery intima thickness kind of tests, or do we need to have angiograms? Or it's very confusing, especially for the likes of me, who's not a medical doctor. I'm a dietitian, but I need to still, I understand how to, I think I understand how to interpret blood markers, but it gets a bit overwhelming, all these tests. And so I think what you do so beautifully in your lecture is you really break it down. You look at the research, you look at the clinical implications of the different risk assessments, and you talk us through them. So I think before we move on to your keto trial, let's maybe talk about the different risk assessments for a second. Maybe we can actually start with LDL cholesterol and lipograms and other blood markers. Can you tell us if this is a good risk assessment? Should we be looking at this as medical practitioners? And what do we do with the information that comes back on these from the labs?
Yeah, so there's a lot of labs, as you said, and I think it can get very confusing for many people. But my approach has always been we have to find out if the person is at risk, and then find out why. So, for example, if we started with a CT scan and we do a calcium score or a CT angiogram and say, oh, you have blockages in your arteries, I need to figure out how to treat you. Then you could look for inflammation, C-reactive protein. You could look for lipid abnormalities, LDL cholesterol. You could look for diabetes, hemoglobin A1C. You could look at their blood pressure and say, that's the reason you have plaque. That's what I need to treat. So I think we've been doing it backwards for a long time, getting all of these markers and saying we got to treat everybody for everything. And some people just have no plaque in their arteries. They have clean coronaries, and only a third of us will ever suffer and die from heart disease. So how do you know if you're in the 1/3 who's going to suffer heart disease or 2/3 who will never suffer heart disease? We need to look into the heart. So I think we're changing that algorithm in cardiology now, and we're moving away from let's get a whole lot of blood tests and try to treat everything. Because some people, they have an abnormal blood test, but their arteries are clean. I've seen little old ladies who have LDL cholesterol that they should have been dead 40 years ago. And we do a CT and their arteries are clean as a whistle and they don't have any problem. And I'm not going to put them on a cholesterol pill because they have no plaque in their arteries. And I'm not going to treat nothing. I'm not going to treat a number. So I let them go and I tell them that cholesterol is not bothering them.
Wow. Well, I think that's very progressive. I wish more doctors would do that, because I do remember looking at the Women's Health Initiative study a while back and seeing that women with cholesterol, I think it might have even been LDL cholesterol, but I stand under correction, might have been total cholesterol, but it was over 5 either way, millimoles per liter, and that they actually lived longer, healthier life and had less chance of cardiovascular risk. It was postmenopausal. But I mean, I think already there were a few studies like that indicated that maybe we needed to be looking a bit more closely and not solely relying on blood markers as a risk factor. But the thing is, Dr. Budoff, that, or should I call you Professor Budoff? Which one?
Matt is fine. It's all good.
Okay. Well, Matthew, I feel like blood markers are so much easier to do and so much cheaper to do, and in many countries us as dietitians can even do them. I know in some countries it's only medical doctors, like in Australia for example, but then a patient is very happy generally to go for blood tests, but as soon as it's these bigger, more scary tests, more expensive tests, they're not wanting to do it. So that's why I wonder how much role that plays in the blood test being the first port of call versus these other tests. Maybe you can tell us a bit about that and tell us about the other tests and whether they're really reasonable to have as first assessment rather than a secondary assessment.
Yeah, so I mean, if you were to do blood tests as a first assessment, the only two that are part of our guidelines are going to be LDL cholesterol, where you're going to want to know what their cholesterol is, and the hemoglobin A1C to know if they have diabetes. Diabetes is important to know, and that's an easy blood test, but you need to know if somebody has diabetes because we treat them differently and their diet should be different. And there's a lot of things that comes with diabetes, even outside of heart disease. The LDL cholesterol is fine to know, but we don't always know whether to act on it as a standalone blood test. So you can get the blood test and you can calculate their risk and say you're low risk, but if it comes back high, as you mentioned, some people with very high cholesterol actually live longer. So it just doesn't affect everybody equally. Cholesterol is generally in excess, could be very bad for the coronary arteries, but some people are just not susceptible to it. It's just like, we all went through COVID and most of us didn't die from it. So we have different susceptibilities for disease and we're not all the same. So, it's hard to do without some follow-up testing if you find out they're high risk, because we don't really know what's going on in their heart until we look into their heart. And a calcium score, at least in the US, is only $99. So it's not an expensive test, but it is more expensive and it is a little bit more laborious than just going to the lab and getting a blood test. But I agree with you. We just need to find that balance.
Yeah. So I think it definitely makes sense that you don't just want to do tests that are going to show up a whole lot of false positives that, I think that's potentially very deleterious rather than beneficial in the long run, especially if we consider the benefits of cholesterol in cases like, I don't know, dementia or, importance for various things, hormones, the brain. But before we move on from cholesterol, because I'm very keen to get into coronary artery calcium scores and other forms of imaging potentially that we should be looking at, I just want to make sure we've ticked all the boxes with this LDL business by asking about things like particle size. Some people might say, well, LDL cholesterol, obviously, if you just look at the total LDL cholesterol without taking into account whether it's, what pattern it is, A or B, whether it's large, buoyant primarily or small, dense primarily, or whether it's oxidized more or whether it's not oxidized, because if it's more oxidized, then it can't be taken back up by the liver as well because it doesn't bind to the receptors. And there's all those arguments. Where do those arguments fit into this risk assessment, Dr. Budoff? I mean, Matthew.
Yeah. So, so I think that the problem is that there's so many different blood tests, and now you're talking about a much greater cost Because
Mm.
if you try to get all these what we call advanced lipid panels, you're going to be spending a lot more money than those scans that I'm advocating. So, I think once you know you have a problem, so once we know you have heart disease, if you had a heart attack, or once we know you have plaque in the arteries, or once we know you've had a stroke, and we say, okay, you have the problem, you're definitely in that third of people who are going down that road of advanced heart disease, then we do more testing to try to optimize how to treat. But if you do all that stuff up front and you spend a lot of money to do oxidized LDL and particle size and particle number and all these other advanced profiles, and then you find out, oh, well, that's all good. Everything looks, you have some problems, but you don't have heart disease. Your arteries are clear. We don't need to worry about it. You spent a lot of money and a lot of concern for the patient, and then tell them that it's not important to them.
Mm.
Doesn't matter. So again, it's just the susceptibility or the ability for cholesterol, whether it's oxidized or not oxidized, to affect everybody equally is just not there. Even diabetes doesn't affect everybody equally. Some people with diabetes do great throughout life, and other patients with diabetes get amputations and go blind and have kidney disease. So even diabetes doesn't affect everybody equally. So it's all, we just have to keep that in mind, that we have to individualize the therapy, and we can't individualize it just based on lab tests. Lab tests only tell us how to treat, not who to treat.
What about HDL to triglyceride ratio? A lot of people are getting all a titter about that, I find, in the space. Where does that fit in? Is it only for insulin resistance, or has it got some kind of correlation to cardiovascular risk? Although I suppose there's a link between insulin resistance and cardiovascular risk.
Yeah, no, I think it's a great biomarker. It's easy. It's on our basic panel of lipids that we get just when we get our LDL cholesterol. We get total and HDL, and you can make those ratios and calculations. Look at triglycerides and HDL and total cholesterol. And even in the old Framingham data, the very first study in the 1950s that said cholesterol is bad, their assessment of cholesterol was total cholesterol to HDL ratio. They came up with that ratio back in the 50s as the best marker of who's at risk. So, I think more recently we've come to this conclusion that LDL is first and triglycerides are second. And you can look at ratios instead of just triglycerides to get a better feel for insulin resistance, which I think is great. I think it's great to identify those patients and be more proactive. But again, you can overwhelm people with different arguments about different algorithms. And I think that's part of the problem. Is I try to keep it simple, especially with my students and residents and other people in this field, so that they don't get overwhelmed with too many numbers. Because it's certainly, I think many doctors get too carried away with too many measurements, and then everybody's confused. They're other doctors, the patient's family. Everybody gets confused about what the right answer is. And that's probably harmful rather than helpful.
Absolutely. I think we all get completely overwhelmed by the cardiovascular space and which markers and which risk assessments, which is why I so loved your lecture. Really, I just loved it so much. I do want to move on to the coronary artery calcium score, I promise you. But there's one more thing, and that's what all these, I don't know, in South Africa, our medical aides love relying on these questionnaires, these population kind of questions where they then stratify you according to risk. And I think, that's been very accepted in many spaces. And then it's used by statisticians. And then, you're told that your biological age is this. How does that fit in? And do you think it is ethical practice that the medical aides are using these kind of risk assessments to stratify people according to their apparent risk?
Yeah, I think almost all countries used at some level population-based assessment where we look at certain factors and again the big five risk factors. You have the big five there that mean something different, but our big five risk factors for heart disease, diabetes, high blood pressure, high cholesterol, smoking, and age and sex are really key in at least putting people into one of three buckets. Are you low risk? Don't worry about it too much. Stay healthy, exercise, eat right. Are you intermediate risk? We really don't know the answer. You're in the gray zone somewhere. We need to do something more to figure that out. Or are you very high risk, right? Because if you have a high risk person and they have diabetes and high blood pressure and they smoke, then they're much more likely to have advanced heart disease, and we probably need to be a little more aggressive. So as long as we don't overprescribe based on those numbers, I think it's not unreasonable to put people into one of those three buckets through the traditional health questionnaires that we use. But again, I think most people get carried away and try to overuse that and go even beyond what we can do and just try to take advantage of that too much.
Well, that makes sense, because I suppose we're, as you say in your lecture, we're stratifying people according to population statistics rather than actually looking at the individual in front of you and saying, are you at high risk? Even if you fall into the high risk bucket, are you actually at high risk? Have you actually got plaques? Have you actually got atherosclerosis? And that brings us finally to your suggestion of a coronary artery calcium scan. It's relatively cheap, as you've said, compared to all these in-depth lipid panels and other blood tests and other everything. Why are you advocating for this test? Tell us a little bit about it. How does it work? How does it look? How does one interpret it? All that jazz.
Yeah, so I mean, it's a very simple test. It looks into it takes a CT scan. There's no dye, there's no needles, there's no injections. You lay down dressed as you are. It's about a 30-second test. You lay down on the scanner. It takes a few pictures of your heart, and that's it. That's the whole test. You get up and you're done. We can see plaques building up in the arteries. We kind of slice the heart like a loaf of bread, and we can see little plaques building up in the arteries. And if you have a lot of plaques, you're high risk. If you have a little bit of plaques, you're low risk. If you have no plaques, what we say zero, or the power of zero, which is at least 50% of people, you have no risk. And you don't have heart disease, and you probably don't need to worry so much about that LDL and the particle size and the triglyceride ratios, because you don't have heart disease. There's no plaque in your arteries. Your arteries are clean. And I think that's very informative for us as clinicians to say, okay, now I know for sure you have a lot of plaque. I got to really get on top of this. There's drugs X, Y, and Z, or treatments X, Y, and Z. You've got a tiny bit of plaque. Let's be proactive. Or your arteries are completely clean. 50% of adults, your arteries are completely clean. Don't worry about it right now. Just be healthy, lifestyle, and maybe in 5 years we'll do another test just to make sure you're not slowly building something up in those arteries and that you're staying clear.
Okay, well, that makes a lot of sense to go and have that done as like a snapshot in time of your cardiovascular risk. Is it, I've heard about, soft plaques and hard plaques, and, the initial plaques are softer and then they become harder. Does a calcium scan look at both types of plaque? What are its limitations?
Yes, so the limitations are we only see the hard plaques. So what we think is, or what we know is that the calcified plaques, the hard plaques, are the tip of the iceberg. That if you have a lot of hard plaques, you also have a lot of soft plaques. That gets proportional. If you have no hard plaques, you have no soft plaques. And generally that's true. So we could use this as a screening test to say, what bucket are you in? If we want more information, let's say we find somebody with a lot of hard plaque, we'd say, well, we want to know now, do you have blockages? Do you have a lot of soft plaque? Is that plaque vulnerable? Then we would have to do what's called a CT angiogram. We would have to give same study, but giving dye, injection of contrast, to now see the details of the arteries and to now appreciate how much plaque is building up in those individual vessels.
Okay, and if it's the same scan, what's the argument for not just injecting the dye and doing that in the first place?
You could. There are definitely people advocating for that now, for sure. The only problem is it's a little more expensive. It's a little more invasive. You have to start an IV. You have to give contrast. There could be contrast allergies or reactions to the dye. But yeah, I think there's definitely a group of people saying, let's just get the full amount of information up front and really know what we're dealing with. So I think, it's certainly an approach. It's just a more expensive approach that would be hard to apply to population health.
Yeah.
Because the cost implications of that. Like, we have to be a little cognizant that whatever we come up with, we're talking about most Americans, or I mean most adults. And when we're talking about most adults, that gets very costly if we try to multiply that out times the number of adults in any given, healthcare system.
Yeah, absolutely. Something else I was wondering is, let's say someone goes in and they get quite an unpleasant surprise with their CAC scan, their coronary artery calcium scan, and they decide to do the interventions, as you say. They're now eating more healthily. We can argue about what that is, but they're eating more healthily. They're exercising. They stop smoking. They stop drinking. They calm down. Their blood pressure. They're getting they're doing all the right things. Is it possible to reverse those numbers on your CAC scan, or are they set in stone and you can the best you can do is prevent progression?
No. So if they're soft plaque, we can definitely induce regression, and we've seen that. We've done some studies with different agents, different medications that have induced slight regression. It's not like liquid Drano. It's not like you have a lot of plaque and then next week the arteries are completely clear, but they can slowly get better over time. The soft plaque, that hard plaque is scar tissue. It's not going anywhere. Once that plaque turns calcified, it's there forever.
So that implies then that from your CAC scan, we're not talking about the dye version, we're talking about just the plain CAC scan, then we shouldn't ever see regression, right? Because that just looks
Correct.
at the hard plaque. Okay, so if someone's got a bad score, the best they can really do, it looks like at this point, is to just prevent it from getting worse on the CAC scan. But certainly if you went and did the angiogram, then hopefully we could see that improving, because that would be looking at the soft plaques. Okay, well that makes a lot of sense. And I think, considering all the research that you present during your lecture, you make a very compelling case. You take us through all the different risk assessments, their pros and their cons, and you make a very, very compelling case, and as you have now, for rather just knowing exactly what your risk is, what the tip of that iceberg looks like, and then whether you need to go and see what the soft plaque or the bottom of the iceberg is doing, and then potentially go on and do other risk assessments to see what we can do, what is contributing to that, whether it is inflammation or diabetes or whatever it is. Then we go and look at intervening at those kind of causal levels. Is that interpretation correct?
Yes. Yeah, I believe that's perfect.
Okay, great. So now I want to move on a little bit into your study that everyone's very, very, very excited about, your keto trial. Maybe you can just take us through what the study looked like. Well, maybe start with why you did it and what it looked like.
Yeah. So, there's this great controversy about what happens when patients' LDLs go up dramatically. And is that bad? Is that just a way that a lean person who's not ingesting any carbohydrates transfers energy? Or is that something pathological that can lead to more heart disease? So we decided to, and working with Dave Feldman and his group, we decided to do a CT angiogram at baseline in patients who are on keto for about 5 years already, see what their plaque is at baseline, follow them for a year, and then do another scan to see what the rates of progression would be. And is that related to the LDL cholesterol? Is that, is there some patients who are not progressing? What's the prevalence of change over time? So that was the background, is to try to inform us better about what's going on with this keto diet.
Okay, well, I think that sounds great, because people who are in the keto space, they all know who Dave Feldman is, and many of them, including myself actually, have got very scarily high cholesterol levels. And whenever we end up at the doctor says, you need to go on statins, this is terrifying. And I say, well, look at my inflammatory markers, and look at my HbA1c, and look at my insulin concentration, and look at my body mass index and everything else, and I feel kind of fine, but we don't know, are we fine, are we not fine, which is why we need to be talking about these scans. So I'm definitely someone who, from a personal perspective and from a professional perspective, am very closely very closely watching your studies. Am I at risk? And so what did the study find? If I remember correctly, you've done 1 year follow-up between the two groups, the people on keto and the people not on keto, and you've looked at their CT angiograms and you've looked at their cholesterol. And obviously the keto group was the lean mass hyperresponder group, very high cholesterol.
Yep.
Did their plaques get worse in that
So
year?
so we looked, so the primary analysis, which was blinded reads in my lab by blinded investigators, is actually being presented next week by Dave Feldman at a conference. Yeah. So that'll be the actual primary analysis. What we did in the interim, because it was taking months to get these blinded reads, because they're manual, they're done by, slice by slice with a human making measurements, is we used one of those newer AI algorithms to measure plaque volume, and we just sent them all the images and they sent us back all the numbers. And we looked at it, and what we first looked at was the relationship between how high the LDL was and whether or not patients were having more plaque progression, and there was no relationship. So the patients with the highest LDLs were not the ones who were progressing compared to those with more modest LDL elevations. Then we looked at the overall rate of progression, and in this cohort, it was a little bit higher. But I can tell you that when Dave presents the final analysis, I think it'll be a little more of a balanced presentation as far as what we found. So I would encourage you, I don't want to give it away too much, but I would encourage everybody, I'm sure Dave will make it well known what he's presenting. I think it's on the 18th of August. So it's coming up in about 10 days. And we finished our analysis, and we gave all the data to our biostatistician. It's all being done by my lab, independent, and then Dave's just going to be the one presenting it. But I think it's pretty sure it's on the 18th of August. Dave's going to be presenting the final analysis of this keto trial. But so far, all we can say definitively is that the more LDL goes up, we are not seeing a proportional relationship with plaque, where we normally do in other cohorts. When we look at patients with homozygous FH, patients whose LDLs are scary high, the higher their LDL, because that's pathological, that's not healthy people, the higher their LDL, the more plaque they get. In heterozygous FH, where the LDLs are more modest, they do get a buildup of plaque. It's not quite as dramatic as the patients with the higher LDL. And the patients with normal LDL, the rate of progression on average is not as fast. So this relationship of LDL and plaque was not seen with keto. So this LDL is different. I do think it's a lipid energy model. I do believe that this study will support that hypothesis, that this is not a pathological LDL, that the body's just using a lot of LDL particles to transport a little bit of fats around at a time, because they don't hold a lot of fat. And we need to have a lot of those LDL particles to do the job. We've had patients with LDLs upwards of 1,000 milligrams per deciliter, very scary numbers, and their arteries were completely clean. Wow. So there's definitely a disconnect between our traditional LDL elevations that are genetic and maybe from bad lifestyle compared to what the keto-induced LDLs are.
Well, I mean, that's fascinating, because it's just brings me back to the contextual nature of diet, really, and how you have to be so careful about interpreting markers and other things within the body in a different context, and it makes me think of, the microbiome assays that they did on like Hadza tribes and various other tribes. They're like, oh no, this is bad because the bifidobacteria is low, but it turned out that actually they're the ones they ended up using for, the fecal transplants to combat the Clostridium difficile, for example. And then similarly, you have the pathological insulin resistance versus the adaptive or physiological insulin resistance, where I know many people who are on keto diets, if they do an OGTT, an oral glucose tolerance test, they come back basically diabetic, because their cells have adapted to using fat likely rather than carbohydrates, and so that it'll take a few days before they can readapt to using carbohydrates again. I know for me, when I did an oral glucose tolerance test in the peak of my keto, I think my blood glucose went up to 12 millimoles per liter, which is very high, and it just didn't come down. But the rest of the time, when I test my blood glucose, I do a CGM, a continuous glucose monitor, or I do finger pricks, my blood glucose stays very, very normal and low, between 4 and 5 all the time. So, am I diabetic? No, I'm clearly not diabetic, but I look like I'm diabetic when I do an OGTT because of the adaptive responses. So I think there's so many examples of this, and it just seems that maybe you've found another example. Then after that rant, I just wanted to comment on your FH. So for the audience who doesn't know what that is, that's familial hypercholesterolemia. So hyper means high, cholesterolemia, high cholesterol, and familial means it comes from your family. It's hereditary. So many of you will know that some families, some people just have higher cholesterol, and this can be really, really, really high. And this is the group that Matthew is talking about. Very high cholesterol. And obviously, if you get 2 genes, you're homozygous for it, so you're going to have really, really, really high cholesterol. And if you have just one, you're heterozygous for it, you'll get pretty high cholesterol. And the indication that Matthew was saying is that, that they're going to have increased risk of plaque buildup in this. So perhaps, why do you think this is the case? Because it's not caused, in this case, it's genetic. I mean, we could make all sorts of arguments about maybe it was beneficial for some people to have high cholesterol, I don't know, fighting infection, or we can hypothesize for all sorts of things about why high cholesterol might be good in these people. Why? I mean, I understand why high cholesterol might be bad if it's induced by diet, but why do you think we're seeing increased atherosclerosis in familial hypercholesterolemia?
I think it's just it's high, not induced for a reason like transporting. It's high because they can't clear the cholesterol, so their LDL goes up, and they have no capacity to get rid of it. It just stays in the bloodstream. So they have no receptors to clear the cholesterol out. So they just keep making more cholesterol, and the cholesterol can't get out of the system. So it stays in the blood vessels. And then it can slowly embed in the blood vessels over time. Not everybody, but many of them do suffer early heart disease. And I think it's because of the inability to clear the cholesterol. So they're not making it for a specific reason, like lipid energy transport. It's not induced from like your glucose induced from an OGT. This is just their liver normally makes a certain amount of cholesterol, which is fine, but then they're unable to clear it. So all it does is circulate and circulate and circulate, and eventually some of it gets embedded in the blood vessel walls, and they do develop more likelihood of having heart disease. So I think it's a completely different pathology and a different reason why it's high, which may put them at more risk than others.
Okay, that makes sense. I'm just wondering, because I think you said that many of them do, but some of them don't. Do you think there could be other risk factors that, beyond just the lack of cholesterol clearance, like other risk factors that could be contributing towards that cholesterol becoming lodged in the endothelial and the blood vessel linings?
Certainly, yeah. I mean, they're not immune to having other problems. So many of them also suffer metabolic syndrome and have that inflammation and have other things that would contribute further, right? Because then you have more insults, if you will, to the blood vessel wall.
Yeah, that makes sense. So other risk factors, are we talking about things, obviously, like you mentioned, things like smoking? Would things like, I don't know, inflammation, what other risks would you say for someone who does have high cholesterol, whether it's familial or whether it's keto diet induced? What are the other risk factors that you feel would put them at increased risk of that cholesterol becoming a plaque?
So definitely diabetes, overt diabetes, the hyperglycemia, the glycemic amount, the glycemia that they get clearly drives more plaque deposits, because now you're insulting the vessel from the glucose and from the LDL both. Inflammation we talked about. I think that's one of the remarkable things that I've seen. With this keto diet, is this increase in inflammation. The decrease in inflammation that we see, and the inflammatory biomarkers go really low, and the triglycerides go really low. And I think that's a marker of very good metabolic health. And they don't have that. They don't have metabolic health necessarily.
Yeah.
Their LDLs are high and they can have other insults. So I think that they're not historically, healthy people who are doing a special diet. They're unhealthy people whose LDL is way too high. And I think that's the difference.
Yeah, that makes so much sense. I see that we have got a lot of questions pouring in. If anyone else would like to contribute their questions, please do. I'm going to start looking at the comments section, and I just wanted to say hello to those of you who have joined us. Thank you very much. Before I moved on to those questions, just one more question about familial hypercholesterolemia, Matthew, and that is, what is your feeling about familial hypercholesterolemics going onto a ketogenic diet?
Can you say that again? People with
Yes, with people with, so you've said like people who go on a keto diet, generally, let's say their cholesterol's normal. When they're not on a keto diet, they go on a keto diet and they get really, really high cholesterol. At the moment, within your cohort, it looks like it's not associated with atherosclerosis. But what about someone with familial hypercholesterolemia whose baseline is very, very high cholesterol, and then they go onto a ketogenic diet? How is your feeling about FH people going onto ketogenic diets? Do you think it's safe? Do you think it's not safe? What are considerations?
I think I'd be a little bit nervous, but just in case they now have a compounded effect of having inability to clear LDL, and now we're inducing more LDL to go up. I don't know what will happen for sure, but I would certainly at least watch them very closely. I mean, we never know what an individual is going to do, to be honest. So it's hard to predict that exact scenario, but I think that would make me a little bit nervous, to be honest. I'm not sure what would happen. Maybe their LDL will go down. I don't think we've tested that type of algorithm before.
Can that be your next study?
Yeah, I'll see if we can find those patients here. Yeah, we'll see how the keto diet affects FH. Familial.
That would be fascinating, because I think many of us who are clinicians in the space have had FH patients.
Sure.
And it's very difficult to know what to do with them. Another thing that we struggle and we don't know what to do with is heart failure, which is why we also have lectures happening in this training on the heart failure. And if we have more time, I actually wouldn't mind asking you more about that and your feelings about keto diets and heart failure. But then we're going a little bit off topic, so I just want to make sure that we cover what the questions in the comment section. So sure. I'm going to start with Kieran, who says, in Ireland we seem to require contrast serum. Do I hear it correctly that we can get good data without the IV? Thanks.
Yeah, absolutely. Yeah, that's a great question. And the parts of Europe have really adopted those, what we call the CT angiograms with the dye, rather than just the calcium score. But the calcium score, I think, is very, very informative. And if it's normal, if it shows 0, which it does in half the people, the chance of that CT angiogram with the dye showing anything is very low. A very remote chance of having anything significant. They might have a little speck somewhere, but really nothing that we would worry about too much. So I think that you definitely can get good information if without the dye. And I think that would be in the US, the first test is without the dye generally. And then if there is plaque of any significance, then we can always do a dye test as a secondary test.
Great, thank you. And then Daniel says, hi, Dr. Budoff. I'm one of the LMHR participants in the CTA keto study and a nutrition advisor with the Nutrition Network. Many doctors still prescribe statins based only on total cholesterol or LDL, even when patients are metabolically healthy. What do you recommend as the most effective way to educate family doctors to focus more on risk-based tools like CIMT or coronary artery calcium scans instead of just lipid panels?
No, I think that's a great question, and thank you for participating. It's certainly, I think we're all going to learn a lot, and I think you'll be happy when Dave shows the overall results. But I do think that I agree. I think that it's a big problem that we haven't yet completely overcome, is how to navigate these tests and how to just get away from just treating the lipids by treating that number without more context. And I think that that's been our biggest problem in medicine. And I think that the more proactive doctors, and I know a lot of doctors who claim to be preventive cardiologists or preventive medicine doctors, understand the need to identify who's at risk with carotid testing or with calcium testing or CT testing before we just jump in there with statins and other therapies. So I'm a big advocate, and I've been trying to educate a lot of those doctors to really know what they're treating and not just treat. If you think about statin, any drug that we give could be like we give chemotherapy to cancer patients. You wouldn't give chemotherapy unless they had cancer. So why would we give a statin, a drug that's supposed to prevent or reverse atherosclerosis, if they don't have atherosclerosis, if they don't have that plaque in the arteries? It just doesn't make any sense. So we're treating a number instead of treating the patient at that point. And I think we need to relook at that and continue to educate doctors that you have to establish that they have disease first, and then you treat the disease rather than just treating a number and assuming that they may have disease or they may not have disease.
I actually think that that's the first time I've heard that logic, but now it just seems so clear and so obvious that that's what we should be doing. You know, before you answered, I would have answered. Now I'm embarrassed to say I would have answered Daniel and said, well, we've got all these studies, and we put together your study, Dr. Budoff, and we put together, you know, the Women's Health Initiative study, and maybe the reanalysis of the Minnesota coronary experiment study, and we look at all these different studies and the studies that indicate that, you know, statins have a hazard ratio below 2 for improving all-cause mortality and cardiovascular mortality. And, you know, I would say, oh, let's do all these. But again, it's so complicated. And like you said in the beginning, we dive into all this complicated stuff when in truth, what we need to say is simply, we're treating atherosclerosis. Let's check if they have atherosclerosis.
Yeah, and you know, there's a great proof of that. In the best trial for the statins that have ever been done for event reduction was called Jupiter. Jupiter took high-risk patients, intermediate risk patients, and put them on rosuvastatin or placebo. And there was a 44% event reduction overall in that trial. But if you look at those patients and do calcium scans, 50% had 0 scores. And in those 50% of people who were on rosuvastatin for 4 years, their benefit was 0% because they had nothing to treat. So their LDL went down, but their event rates were already 0. So you can't make a 0 go lower. So we could identify which half you're in by doing a simple scan, and whether that's a carotid scan if you don't want to do the heart scan, or a heart scan, and look for the disease. And once we find the disease, we then can put you on the right therapies. And that would be, I think in some cases, a statin. I use them in practice, but I'm judicious, and I use them in patients who are truly high risk and not just people whose cholesterol is too high.
Yeah. So again, it's testing before treating. You know, like you say, you wouldn't put someone on chemotherapy without knowing that they have cancer and it's indicated. That makes so much sense. And I think that's why Nutrition Network and Keto Mojo found it so important to launch this Mastering Metabolic Metrics training, because we realized that people are kind of just throwing, you know, everything in the kitchen sink at people without truly testing and discovering what's going on first before choosing targeted therapies accordingly. And and that's also why, you know, we have all the lectures from Dr. Asina Kaji, who's a specialist physician, talking about anthropomorphic signs, symptoms, clinical signs, symptoms. We have Siobhan Huggins, who's good friends with Dave Feldman, also discussing all the blood parameters, how to interpret them. Very, very cautious, very prudent. Yeah, so I think that's why this is so important, because we can't just treat without knowing what's going on. Okay, so yes. Before I move on to Wendy's question, I did want to, you've mentioned the INTIMA test. Can you tell us a little bit about that and where that fits in?
Sure. So an alternate approach to looking at the heart is to look at the carotid arteries. And The arteries that go up into the neck are very easy to visualize with the ultrasound because they're right up against, you can feel your pulse here. That's your carotid artery. So we can put a probe there with ultrasound and see if there's any plaque building up, any atherosclerosis, any heart, any vascular disease building up in the carotid artery, and then know that you have the disease. The only problem with that test is that's not quite as reproducible, because if you move the probe a little bit left or right, it could change the results. So you really have to go to a good person who does it well. But it is another way of looking at the heart, or the vascular tree in the heart, and look for atherosclerosis. And if they have plaque, then again, I think more aggressive treatments are warranted. And there's many options, beyond things like statins. But there, I think you would be in that category where I'd say we need to do something here. It's time to start treatment.
What treatment options are there apart from statins? Are you talking more medication options, or?
Well, there's lifestyle changes there. I've done research with garlic showing that with aged garlic extract, you can lower LDL cholesterol. There's certainly great, diets and lifestyles, exercise that help modify lipids and plaque in the arteries. We actually did a CT angio trial like we did with keto. There was a trial done called the DISCO study that used diet. And they showed that with diet alone, you can reduce some of the plaque components in the arteries with CT. So we definitely have a lot of options. Some people use red yeast rice or other supplements. There's stanols and sterols, things that you know more about than I do. Ways of absorbing cholesterol from your gut with certain foods to prevent heart disease, fiber. So I think there's a lot of approaches that we could take. And then there are some other pills that are probably not as toxic as statins, like bempedoic acid, which is inhibits cholesterol. It's a newer therapy. It inhibits cholesterol, but it doesn't have a lot of those same toxicities that the statins do. So I think we do have both medicines, lifestyle, and complementary therapies that we could apply for patients who have high cholesterol, who need treatment, who have heart atherosclerosis and need to treat that cholesterol.
Well, I really hope that all doctors and all cardiologists listen to you, because I really think we need more nuanced approaches, more individualized approaches that look at all these options. What's the best for the patient in front of you? Are they able to exercise? Are they willing to make dietary changes? Are they more inclined towards supplements? What are the natural alternatives, or let's call it nutraceutical alternatives, that they might want to try? Maybe if they're too far gone, you don't want to go in soft, you want to go in hard, and you need medical doctors who know how to do that. So that's why I think your lecture is just so incredibly important. I did want just one word of caution. I did work in the supplement industry for my first 6 years, and many of the supplements are actually just medicines themselves, really. Like, for example, red yeast rice is a statin. Its active ingredient is a statin. So I do think that, I just want to tell our audience, I think it's always best to proceed with caution. Go to someone, if you can be as lucky enough to go to someone like Dr. Budoff, who knows about these things, who can advise you appropriately, and just be cautious that when you do use supplements, that you use evidence-based supplements in the correct doses, in the correct forms, under the guidance of, especially if you're doing it at medicinal levels, because nutrients can be nutrients, or they can act as medicines as well, generally at higher doses in extract forms, things like that. So definitely you want to be guided by someone who knows what they're doing, just like our Matthew Budoff here with us. We have got another question. Wendy asks, if a coronary artery calcium score is 0, triglyceride to HDL under 1, but cholesterol is 350, is there a need for concern or further testing? This is just a hypothetical case, I'm sure.
So the cholesterol is high, and what was under 1?
So triglyceride to HDL ratio is really beautiful. Yep. Under 1, and coronary, and your calcium score is 0.
So I think, I am and the guidelines around the world support this, including Australia, New Zealand guidelines, and European guidelines, and US guidelines, that if the calcium score is 0, you're low risk and you don't need to worry about your lipids for the next 5 years. So that's the perfect example of somebody who their LDL cholesterol is high, everything else looks fine, and they are not building up plaque in their arteries. And I would ignore that number. I would say 5 years from now, let's test you again, because you don't have a lifetime immunity to heart disease. And as we get older, we change with menopause, or we change with developing more blood pressure problems or diabetes problems as we get older. You want to check again at some point. It's not a lifetime warranty, but it's a great 5-year warranty that score of 0 will impart that you don't have plaque now, and in the next 5 years you're not going to have any events, and you're going to have very low chance of building up any significant plaque. So you can work more on lifestyle and not worry so much about that cholesterol value.
That's very helpful. And if we have the kind of 5-year rule for coronary artery calcium scores that are 0, what if your coronary artery calcium score is higher and in the at-risk range? Would you then recommend a next test more like sooner?
Yeah, I think if you have a little bit of plaque, I would be a little more proactive about that cholesterol. Again, we have a lot of ways of dealing with that, with lifestyle, diet, and other things. But I would test maybe at 3 years, let's say, and not wait a full 5 years if it wasn't 0, because it could start. Some patients it will start to go up. Some patients will stay nice and low, and some patients it'll go up. And we can never predict without testing exactly where you're going to end up, because I've seen very, very healthy looking people suffer terrible heart disease at a young age, and I've seen very, unhealthy looking people who live a very, very long life. Our classic example is always Jim Fixx and Winston Churchill. So Jim Fixx was a very famous runner in the U.S., kind of developed running as a lifestyle change to help with heart disease. He died at age 52 of a massive heart attack. Winston Churchill, never seen without a cigar in his mouth, huge, overweight guy, very unhealthy, lived to 92 years old. So we're not all the same, and we don't all have equal susceptibility to disease. And we just have to look and see where we are. Do we look healthy and are not healthy like Jim Fixx? Do we look unhealthy and are doing great like Winston Churchill? Or most of us are going to be somewhere in between.
Yeah, I think that's a really good point. And I actually, when the questions slow down a little bit, I actually wanted to ask you for some anecdotes from within your practice, because I think it makes people it becomes real for people. But before I do, I see Daniel has asked about HDL. He says, it seems much easier to lower LDL and triglycerides in clinical practice, but do you have any evidence-based tips for insights on how to meaningfully improve HDL in patients?
Yeah, so we've failed at raising HDL in many, many different trials. Niacin is probably the best, but the very large trials didn't really show as much benefit as we hoped. But probably your best way to raise HDL is exercise. Alcohol raises HDL a little bit, and niacin, B vitamin, niacin supplementation raises HDL.
Right. It also dilates your blood vessels.
Yeah, for sure.
So it's multiple benefits. Might make you look a little flushed, though. Our Fig says that this is an absolutely great interview. And as an lean mass hyperresponder, it's very difficult to find a doctor who will work with you without the physician being condescending. I can totally relate to that. So before our pro here contributes, I just want to say, from my perspective, you got to just keep looking until you find a physician who's willing, when you hand them the research and you say, I want to be tested before treating, that they're willing to go with that. So, I think that's in my case been very, very helpful. But Matthew Budoff, what's your opinion about that?
No, I agree. I think we just have to be careful. We have to think about, do I need this treatment, and will it benefit me individually, not based on population-based studies, but personalized medicine. And I think that's where we need to end up. We need to figure that out in a proactive way. Is this something that's going to help me as an individual? And again, everyone's a little different. You asked for an anecdote. I had these 2 younger women come and interview me once, and they both look very, very healthy, thin, fairly young, and they wanted to get the heart scan. And I'm like, oh, you're kind of on the young side. And they go, well, our dad had heart disease. We have family history. And they had this big, heavy, older cameraman. I'm like, well, why don't we do the cameraman? He's more likely to have plaque, and I can show you what it looks like on the screen and see what it looks like, because I thought they would have nothing. And cameraman was clean. One of the women had nothing, and the other woman, and they're both their sisters, had a really high score. And even somebody who's been doing this their whole career, looking at people and trying to make assumptions about what's on the inside from what's on the outside is really, really hard. And that's why we need a carotid IMT, or we need a calcium score, or we need the CT angio with dye to help guide us in who needs what and when.
Wow. Well, I've got my own anecdote about this. Not nearly, now I realize, as evidence-based as yours, but I, ran bloods on 2 patients in front of me, a couple, and I saw the lady, and she was much more overweight than her husband. And I thought, oh, here, she's the one who's going to be insulin resistant. Her triglycerides are going to look terrible. Her HDL, her LDL, everything's going to look terrible. She has a lot more weight to lose. And this husband, he's going to be okay. I looked, and it was the opposite. It was the absolute opposite. And then I thought, you can't judge a book by its cover. You need to test. And, there's a lot of talk in the space about the ability to potentially, gain fat as a protective mechanism before it starts spilling over. So I think, or at least the fatty acids and the inflammatory cytokines and everything else start spilling over. So I think yours is a more evidence-based, nuanced way, or visual way of really looking at that, and not judging a book by its cover, really looking inside that book to determine what the story is, which I think is so important. Yes, Daniel, my face about the alcohol, let's all use alcohol to raise our HDL. What a great idea. No, I'm joking. Yeah. So I wanted to end off with maybe some just last kind of thoughts and nuggets from you when it comes to, if you could envisage a perfect healthcare system with perfect doctors, what would your advice be to them, and what would it look like? So just paint a picture for us of how healthcare should be when looking at cardiovascular health and risk.
So, from a perspective of a
clinician, what should they be doing? How should, when they see someone in front of them, should they test that 20-year-old girl in front of them because of your story? Maybe they've got plaque, or like, when should you be teaching? When should you be testing?
So I think, so we talk about the age of atherosclerosis. When do people start building up plaque in their arteries? And it's probably in the late 30s, early 40s for men. It's probably in the late 40s and early 50s for women. So a 20-year-old woman is not going to have disease 99.9% of the time, and we shouldn't be looking for it. If they have some risk factors, we use lifestyle only. We work on a healthy diet. We work on exercise. We work on eating right and maintaining a good body weight, not smoking, things like that. As they get older, we can start thinking about testing. But again, it's going to be closer to 40 years of age for men and probably closer to 50 years of age for the average woman. There are exceptions, patients with terrible cholesterol, patients with early onset type 2 diabetes, patients who have really advanced family histories. We might want to test them a little bit earlier, but we can't get into this idea that we can start looking for heart disease at age 10 or 20 and find anything meaningful. They might develop it in the future for sure, but it's too early to test.
Thank you. Okay, that's really good. So I think we have a good idea of how we should be testing, looking at the CAC first. If we're seeing problems, we go on to the CT angiogram. We start maybe looking around 40 for men, around 50 for women, unless there are other big things going on. And then we complement whatever our findings are with blood tests and other parameters or markers to determine the best intervention strategy for the patient in front of us. I think that would be kind of my take-home strategy as a clinician.
For sure.
have you got any last things you would like to leave our audience with before we say goodbye and we wrap up?
No, I think it was very comprehensive. Thank you for having me on. I've really enjoyed the conversation, and I hope this helps some people put heart disease in a better perspective.
Thank you so much. This has been, I know, incredibly helpful to me as a dietitian. So I can only imagine how helpful it is to the rest of the allied healthcare practitioners and medical doctors, and then lay people alike. You know, many, as you can see in the comments, many LMHRs out there and other people I know, family members asking. My dad's always asking me about cholesterol and what I think about it. So I know that, you know, family members is really valuable to all the people who are listening. So thank you so very much for this. And that brings us to the end of this discussion, everybody. I do want to say, please do sign up for the Mastering Metabolic Metrics training that launched at the end of last month, where you can hear this lecture, you can get access to everything that Matthew has been speaking about, and all the papers where he takes you through every single risk assessment and why it's good and why it's got some, you know, challenges, and all those kind of things. It was everything I could have wished for in a lecture, and I've really wanted to know about this topic for a long time. So I think everybody must please do that. And then we are now at the end of this month launching a training on cardiovascular health, which is way overdue, considering that this is the reason that people worry about keto, really. So for us in the therapeutic carbohydrate restriction space, and for those of us who've been doing it for many years, I myself have been on this way of eating since 2012, a long time. This is the one big question mark that everyone's had, you know. Does it raise your cholesterol? Does that translate into cardiovascular risk? You know, and then we dive into other things like blood markers. We have what is, you know, lipoprotein little a, what is it? Should we be worried? How do we interpret that? Siobhan Huggins talks on that during this training. It's great, very interesting. Then we have discussions around stress and around exercise post myocardial infarction, and we have coaches on here. We have all sorts. We have professors, we have cardiologists, we have all sorts on this training. Also going into lean mass hyperresponders again, more into risk assessments. So please sign up for this training as well. It's really important, especially if you're in this space, but even if you're not, to be honest. So thank you so much, Dr. Budoff, for taking the time to unpack both your important new research and your broader insights into cardiovascular risk assessment.
It's been a pleasure. Thank you for having me on.
It's been wonderful.
Take care.
So anyone who wants to sign up, go to nutritionnetwork.org or go to email support at nutrition-network.org. And thank you to our whole audience as well for joining us. And we will see you next time. Thank you, Dr. Budoff. Such an honor. Goodbye.